Hello viewers, I'm Natasha Smith and today we'll be doing a COVID update where we'll be interviewing Ms. Pheona Mohamed of the National Reference Laboratory. Ms. Mohamed, good day and thank you for being
Thank you,
here.
Natasha, for having me. I'm happy to be here and I'm happy to give you an update as it relates to COVID-19 and our testing capacity within the National Public Health Reference Laboratory.
Okay, tell us about this laboratory first of all and your role there.
So the National Public Health Reference Laboratory, as the name implies, is a laboratory that specifically deals with public health. And presently we're dealing with a public health crisis. That's the COVID-19 situation, the COVID-19 pandemic. But apart from COVID-19, the National Public Health Reference Laboratory will do all infectious markers, meaning all disease that can spread via infection, including HIV, dengue, leptospirosis. Some of those persons in the public will be aware of. My role over the last few weeks have been to look at our systems that we have there and try to improve what's going on with regards to testing. As you would have noticed, the number of cases in Guyana has been increasing. And one of the reasons for that is that we're doing a lot more testing, a lot more samples are being taken off. And as a result, we seem unable to meet that demand. So I've been specifically asked as a laboratorian for more than 20 years to look at our systems that we have there and see if there are avenues that we can improve and increase our capacity for testing.
Okay, since you came there, what have you been doing to improve this capacity?
So initially, I would have done an assessment to see what is our capabilities with the resources that we've had. And the good thing is that we have a lot of infrastructural support, meaning that we have the equipment to do the test. Our constraint specifically has been staffing and the amount of competent people that we have to conduct the test. So over the last week, there's been a lot of planning in making additional teams available for testing. And in so doing, we have asked persons from other non-essential areas to come into the laboratory to provide that support. And we have also we started to conduct a training to facilitate that sort of improved competency among the staff.
With the staff now complemented and having more staff available, what is happening out in the fields with regards to testing in the different regions and so on?
So based on what we're seeing is in the fields, there's a lot more samples being taken. So for example, on an average, we'll get between 200 to 300 samples on a daily basis. But our laboratory's capacity currently is only able to test maybe a maximum of 140. So there's always that backlog of samples waiting to be tested. So with this training that we're having for the staff, it is hoped that maybe within the next week to 2 weeks, we can improve on that, increase our capacity to 300 samples, right? But that means we'll have to extend the hours of services that we have, and we'll have to build the number of teams that we have working. So the aim ultimately is to work 24 hours, and that will be facilitated through training over the next 2 weeks, to improve the number of persons that we have capable of doing the test.
Take us through the testing process from when you actually take the physical examination.
So let's talk about a patient who comes at our East Street triage area at Georgetown Public Hospital. A patient will come there, they will be seen by a doctor. Well, obviously, them going there means that they have symptoms suggestive of COVID-19. They'll be evaluated by a doctor. There's a checklist that they use. And once the doctor specifies that this patient has the signs and the symptoms suggestive of COVID-19, they are going to be screened or they're going to be tested. The test that we use is a nasopharyngeal swab. That's a swab that goes through your nose down into your throat almost, so that we can get as good a sample, because if it's not done properly, then you're not going to get the results that the patient is actually true of. If we don't get enough specimen, then we can give them a falsely negative results when they actually have COVID-19. So that's why it's important for the doctor to get a very good sample, taking that swab into the nose, down into almost where the throat is. So that sample is taken, it's placed in a specific tube that has a media inside to preserve the virus, and then it's placed in a cooler that also preserves the virus. It is then transported to the National Public Health Reference Laboratory, which is right in the vicinity there, and it's accessioned. Now, in accessioning, what the process entails is that the staff who's working there needs to ensure that the sample that they receive matches the requisition form for the test. Also, at that time, they will do the necessary labeling for the sample to be tested. Now, because of the number of samples we've been getting, that process can be between 1 to 2 hours, depending on how many samples, because we want to make sure that we don't miss anything, we don't make any errors. When that process is through, then the sample is transported into the testing area. The testing area is called a PCR suite or PCR department. In that area now, there's specific staff that takes the samples through the process. There's a staff who is going to do a process where we call extraction. So they take the sample, they place it in a specific mixture or reagent to get the material that we need to test. And that's called the RNA. When that is through, then that process is complete, then it goes to another area where it is taken through a process where you multiply the amount of viral material is there. If there's viral material there, then it's multiplying. It gives you a color change. It's called an amplification process. And then you're able to say that it's tested positive. Now, at the point of extraction, in our current system, it's a manual system. So extraction is another 2 hours it takes. So 2 hours at accession and 2 hours at extraction. And then the amplification process takes between 2 to 4 hours. So the entire process is a very long time. One of the things that we're hoping to do is to decrease that time that it takes for extraction by procuring a machine to do that. These machines can do like 9 to 6 tests at one time, whereas a staff can only take about 12 in about 45 minutes, and that's the most competent staff. So those are some of the areas that I have identified and that the staff who are there have identified, and that we're hoping that we can change to improve how fast we can get these results out.
Is the average time for them to get back their results?
Ideally, if we did not have all of these samples that we're incapable of completing on a 24 hours basis, it is 7 to 2 hours for the entire process to get the sample tested, to get the reports completed and sign off and so on. That's being, ambitious. Realistically, because of what's happening and the number of samples that we're unable to process in a 24-hour period, it's taking at least a week. All right? Because, as I explained, the entire process is very time-consuming and labor-intensive. So those are some of the things we hope to change. If we have more teams working and we can utilize the entire 24-hour period, then we should be able to have more tested. If we have the equipment that can extract the sample, then we can have more extractions. We can decrease that time that's done, and also improve how fast we get the results out.
There may have been some instances where a person had to retest. What would cause such a situation?
Do you have an example?
There were reports from Maruka that persons had to be retested. um, because of a false negative or something like that?
Good. So if you recall earlier, I told you if you don't get a good sample, then you're going to get a false negative. If you don't get enough of that mucoid material within the nasopharyngeal space, then you're not going to get enough of that viral RNA to produce. That's one reason. Another reason is if the sample is taken before 5 days and if it's taken after 10 days, right? Because before 5 days, you don't have enough viral material in the body to be able to retrieve from a nasopharyngeal swab. And similarly, at around 10 days, the virus is already peaked in your body, and then it starts moving out. Your body starts shedding it out, so you don't have enough to get that sample. So those are two reasons that you can have false negative results.
Going forward, is there any other method that you plan to introduce to the system?
There are options that we're looking at because this method is such a long method, and I know you were in the media, you would know that this is not unique to Guyana. It's happening all around the world. People are waiting for a number of days because the method is time consuming and the number of samples that the laboratories have to process. So there are other methods that can improve how fast you get the results. These are called antigen analyzers, where they look for the virus and they're able to produce a result within 15 to half an hour, depending on which machine you use. In our country, we do have some of those machines called the Gene Expert. I don't know if anyone has ever told you about those before. These are machines that we currently use to do TB testing, and we have some around the regions. And it allows us the platform to do COVID-19 testing. So that's an avenue that we're exploring right now to see if we can procure the reagents to go with that. We need to procure the specific kits and the software to make that effective. There are also other methods that have not been approved. I know persons would have heard about the rapid testing kits. I don't know if you've heard about that before. Unfortunately, because the method or the principle of that test is based on your body's response, you're not able to use those tests to do diagnostics. It's used more to see for patients who've had a previous infection and tell you if what's happening in your community. You may have had persons who've already been infected and are now in the recovery phase or have recovered. So those are the uses of those tests. We do have some donations for that, and we're currently working out how we are going to effectively use that those kits to give us information to see what's happening in Guyana.
Okay, and staff are trained in those methods?
It's not a difficult method, but no, I can't say that staff has been trained. In fact, we are hoping to verify the kits so we know how it's going to perform in our population. So when we say, okay, 80% of the time it gives you a true positive, or 100% of the time it gives you a true negative, so we can analyze that data and apply it to our population. So over the next 7 to 10 days, we're hoping to get that verification process completed, and then the plan is to get someone who is recognized and is capable of doing a video on how to use that, because it's basically a finger prick, a place on the kit, and you just have to interpret the results. The interpretation part may be the most difficult part. So we'd want someone to do some sort of training with that, and everything can be done virtually now. So get somebody to pre-record that and send it out to the areas that we'd want to test that in that way.
Okay, what is one of the biggest challenges you have in testing for COVID especially?
As I said before, our biggest challenge right now is human resources, and we're tackling that. Hopefully within the next week to 2 weeks, we have improved number of persons, increased number of persons who can do the test, and we're able to develop a system where we utilize those persons to the max to get the samples processed in a timely fashion. That would be my biggest.
And what's that number?
What's the number we're working towards? Ideally, I would say 24, but realistically, I don't know that we'll be able to get 24. Maybe we'll be able to get 18. So, but we're working on that. That's a work in progress. The other issue that we have, as I said, the other challenge is the time that it takes. And again, we're looking at avenues to improve on that. And the third challenge is to probably decentralize the testing. So everything doesn't have to come to Georgetown to be tested. And to do that, we'd have to get those gene expert machines working or methods similar to that to roll out or place in the regions so that they can get, and then you develop a system where if a patient tests positive, then you do it at the central level to do a sort of confirmatory test on that patient.
Okay, I have a question here. Recently, there have been training for medical technologies in molecular detection for COVID-19.
So, yes, in fact, that training started today. We would have collaborated with PAHO Guyana and PAHO Washington. Dr. Adukro has been very supportive in this drive to help us to control COVID-19 in Guyana. And our minister would have reached out to him requesting his help in getting our staff trained or getting improved numbers of staff trained. And so this morning we had one of a two-part theoretical session, and then we're going to have the individuals who are successful at that training involved in a practical session, because the theory has to be conducted in concurrence with a practical session so that you can utilize the staff.
Okay, any other topic you would like to clarify as we have the airtime?
I would specifically like to appeal to the public to understand our challenges right now and to have the hope that these challenges are being addressed. I ask them to be patient. I know it's never easy for someone to be waiting on any results, whether it's a COVID-19 results, a dengue results, a malaria results. There's always that amount of anxiety that accompanies that. But our laboratory is working to fix the turnaround time, or the time it takes for you to get back those results, and we ask you to be patient. Over the next week to 2 weeks, I am hopeful that this is addressed in a definitive way, and that we are able to meet our turnaround time of 48 to 72 hours.
Thank you for watching. Today, with our COVID update, we focused on Dr. Pheona Mohamed of the National Public Health Reference Laboratory.